myself. Yeah.
Okay, so then to start, actually, I start my video as well. And good evening, everyone, and thanks for joining again. Hopefully, this will be a very interesting, a short presentation, a little discussion. For today, we prepared something that is, I think, for the interest of both of us. I mean, both sides of the table, patients, maybe relatives as well, who have IBD in the family, as well as doctors. And today, I'd like to actually share all the experience, and it's not too much. You will be surprised, I guess, that was gathered around, the patient preference and exploring patient expectations and what actually all the scientific literature published around in the last couple of years with regards to the special focus IBD. And now, this will be just really the overview of what patients and what relatives would expect from an IBD care, from their specialist. What are the priorities? You can think about yourself. What do you think yourself when you meet or when you met your specialist for the first time, or when you change your specialist and you meet your new specialist after some years being in this dungeon of IBD, and then about the disease, about plans, about medications, about long-term anxieties and maybe work and life as well. So without any further ado, I'd like to start. And I just would like to announce, as you have just heard, that the next meeting will be actually our virtual fundraiser. I'm really happy that we got this up. And despite all the hassle and difficulties this year with the COVID and how this affects all of us, not just the patients, but also I guess everyone, including the healthcare workers and the specialists here, we are able to actually host you, hopefully, at this fundraiser, and we like to entertain you. And then Emily will tell a little bit about the story later, but you should be there because somebody will read your mind, and it will be not me, much more professional than me. So hopefully it will be really an enjoyable evening. Coming back to our today's presentation, after this presentation and the gala, we plan to continue. We'd like to be there, visible for you. So hopefully next year we can set up soon a schedule of 2 free lectures around every quarter or so, just to chat, to talk, to give you a platform to interact with us, the IBD McGill Center specialists, as well as within the patient group or the patient organization. A little bit of discussion, around the topic, and then of course, whatever issues you would have, you can raise the questions here. So today, again, exploring patient expectations. And I really love to start with some word clouds here, because whenever you ask in the public, and this is just, the, internet cloud, I would say, that you revolve around colitis and Crohn's disease, then already here you see that, yes, of course, it includes health, medical, PAL, so the usual, I would say, words that you would expect, but it includes also pain, illness, or just life, a lot of other things that we might not directly associate right away, as the first, start. So it's really, really a broad spectrum, not necessarily just the gut, the intestine, but really the whole life and how it affects, the patient's life. And this is what I always show as well when I talk about IBD at any forum, be it a resident, for patients, for specialists. You see that the IBD is not the disease of the gut only. Medically speaking, you have a lot of other problems. You have extra intestinal manifestations. You might have strictures. You might have extra intestinal manifestations of the skin. You see there's some, inflammatory changes there. You might have problems with the eye, with the joints, as well as the biliary tract and sometimes the liver. So it's really more broad. And if you look at the impact of the extraintestinal manifestations, I'm really focusing like out of the box and a little bit of how the IBD is affecting the life of the patient, then actually the patients voted that the extraintestinal manifestations are somehow, somewhere a lot of times often worse than the IBD itself. So you have to think about really more than just the IBD whenever you're treating your patients, and think about other aspects, other medical aspects, or even other than medical aspects. And this is the psychosocial emotional part of the IBD, which is the next cloud that I wanted to share. The first was more the medical terms, and this is more the personal life and how it affects the personal, life measures and events of everyone with living with IBD or being related to an IBD patient. You see a lot of things there about friends, about work, about community, about how you feel. And this is the, let's say, the day-to-day, and then of course the longer term plans. And then we'd like to question and we'd like to discuss a little bit around the patient's global expectations, the patient expectations at around diagnosis, then the patient expectations from therapies. I go back to normal, what do you want to know about the therapies? And then of course, during follow-up, when you are in remission and in control, you might be more concerned about the longer term therapeutic plan, as well as some risks that are associated with IBD, maybe cancer, maybe long-term support and plans and changes. And then of course to start with, we can discuss about the shared decision making. I think this is very much what my generation probably of the physicians understand. We'd like to partner. We don't want to all the time lead this discussion, but we really like to partner with the patient and actually share or interest as well as or knowledge, and then with the suggestion that we give, get to a compromise and have the buy-in from the patient from the get-go. So when we think about the decision making in IBD, clinicians, of course, mainly focus on the symptoms of the disease, getting the symptoms under control, getting the inflammation under control, be it biomarkers or visible. And then of course, the patients might have other questions more related to the quality of life, how they feel, and of course, other interests about their long-term outcomes with the disease and the medications. In global, if you ask in a survey, Europe or Canada, what patients really think about, as health preference and expectations, what are the #1 questions around, their, IBD and related questions, then you see that it's all about quality of life, all about pain, resolving of the symptoms. And then high up on the list for the patients, high up on the list is to achieve a control objectively of the inflammation. I think this is much more related already to the education that we actually provide the clinical specialists. So they want to have a good quality of life, no pain, complete resolution of the symptoms, and then mucosal healing, normal colonoscopy. So basically all aspects of the disease under control. So if we ask in the US, and that was actually a very funny experience, what were the #1, #2, #3 priorities of the patient in a discrete choice experiment. And you see again in the US, not much different from Europe or Canada, it was control of the symptoms. And why I show this survey, because at the second, actually, that was some long-term risk management that popped out with them. And then since it was more focused on the biological therapies, no surprise that the third discussion point about the biological treated patient was a treatment-related question about how you administer your medication. Again, here the goals for the patient and physicians might be a little bit different. You see the patient preference is more balanced as compared when you go the right side of the picture than the physician's preference, and I especially highlight the second very steep linear. then you see that line is very steep. That shows the control, the symptomatic control was outweighing probably everything else for physicians. So we have to get these two, expectation profiles, I guess, closer during the discussion and agree on our plans that is actually suitable for both the physician, I guess, and the patient. And yes, the patient want to be involved. So if we go further, another two surveys some years ago in Japan and Europe, you see that almost all patients, I would say 80% or plus, they think it's very important to be actively involved to understand the decision-making of the short and long-term treatment plan, as well as, I guess, the medication plan. Quite important, I would say, is almost the same. So altogether is really literally 100% in Europe. And in Japan, it was exactly the same. Very, very few patients agreed actually that the decision is more or less dictated by the treating physician. Most of them, they wanted to be involved. And then how you can be involved in the current era, and especially now, what we have learned from the COVID or during the COVID, that actually the online aid, the online tools with the partial self-management and the involvement probably in the background of the specialist can be very, very helpful. This is a experience, a clinical trial actually that was published from the Nordic countries in Europe. And that was an online tool that the patient logged in, they put in their clinical data, symptoms, and then the program actually advised whether it's still in remission, whether they do have a worsening. They could even have a map of how they're doing with the symptoms. And then at some point, the clinician was alerted and they together probably managed, the disease or the flare if that happened. And you see clearly that if you have a web-assisted, more objective control, more objective regular follow-up, then the outcome as to whether they had actually a flare or they remained well controlled was quite different. What the patients expect from the IBD care, that of course is a little bit different from what is the most important question. They want, of course, information. They want communication and daily involvement in the care. I just showed you the shared decision making and how some online tools could help with that. They want a good coordination between the specialist and actually their own family doctor. And of course, they want to have a lot of information on the possible therapies, and not just the efficacy, but also the safety. And this is something that we did here at the McGill IBD Center. I'm actually very happy to show these data. You see here that, if you really ask about, how the patient rated the quality of care, everything above 8 would be actually a quite good, outcome. And you see that the patients who have care with us at IBD Center, most of the time were satisfied with the care. Of course, accessibility, it was there a little bit lagging behind, notwithstanding that sometimes, of course, the receptionist is difficult to reach. Now we actually changed that. We have a 24/7 email, we have rapid access, and then whoever has any special question or specific question or symptoms that might suggest a flare, they can pop in with the email and get an appointment within 2 days. So hopefully we actually improved that outcome as well. What you always have to know as a physician, and I guess, as patients, you agree, patients want to have information. However, the distribution of what type of information they need, that might be a little bit different as to whether the patient has just a diagnosis. So this is a new diagnosis of the disease, whether they are having a flare, whether they have clinical remission. At the diagnosis, most of the time they are seeking general information about the disease, about long-term plans, outcomes, and risks. At flare, at active stages, of course, no surprise, they want to get information about possible therapies, medical therapies, and needed surgical therapies, side effects, and outcomes. And in remission, they are much more interested in research and then the new developments, the landscape of the future, or not so distant future medications that will enter the market. The information need is, of course, what you see here is not just restricted to the disease or the medication. We want to have sometimes information on the long-term plans and prognosis as well. And then you see, however, that the information related to symptoms and sudden and short-term complications were regarded as the most important here. How to adjust medication, how to self-manage. It comes back to the shared decision-making and sometimes the online tools. That was rated as very important here as well. And the preferred source of information is, of course, a direct contact. So you can acknowledge that the patient, they want to have really the discussion with their specialist or the IBD nurse. Of course, they seek information, from family members, pharmacists, the web, or friends, but the preferred source of information would be really a dedicated discussion with a medical specialist or a dedicated IBD nurse. And how good we are doing, we're not going so good. If you ask in a survey, then about 1/3 of the patients would not be able to tell about, the disease extent. Maybe they are having some knowledge about whether they have Crohn's or colitis. Sometimes they are even a little bit unsure of that. Then a lot of patients think that the disease is affecting their life expectancy more than what it is actually. And then you see here a quarter of the patient, they were actually thinking that the colonoscopy is having a severe complication rate, and it might be a likely complication or perforation during a colonoscopy, which is luckily not the case. Again, there you see on the bottom line that in this very same survey, the patients estimated the long-term feared outcomes of cancer much higher than what actually it is. So we need a lot of education, I guess, since these data are really not representing what is known from the specific scientific literature. So about 1/3 of the patient, they really need more information, and we actually do not provide that. This is just a specific paper that was discussing the cancer risk, and you see there that it's really about 30% or more who were thinking that the cancer risk is very, very high. So a lot of misinformation is present when the patients are on their own and not get direct source of information from the medical specialist again, or discussion with the IBD nurse. About the chronicity and the new diagnosis, of course, you see there again that most of the patients, they really want to have a detailed information, expert advice from their specialist. So this is almost universal about the disease, about access, about how they get along with their disease, with the IBD. And then when it comes to active stage, when they have symptoms, when they have a flare, then again, no surprise here, they want to have information about their therapy. And the most important factor that they are interested in is really the symptom relief, so efficacy, in other words. And then the second question mark there is, or the second highest bar, is for the side effects. Everything else about cost, about daily dosing, about number of pills, route of information, route of administration was actually weighted less than the efficacy and the side effects. Different survey here, you see again efficacy and side effect. And then we have to know, and this is I think a little bit more important for the teaching or for residents and the IBD specialist, that the symptoms are not only the symptoms that we usually ask for the IBD patients, since we always ask for diarrhea, pain, and probably bloody stool and some fever and other complications, but fatigue and bloating were really the most frequently reported symptoms in Crohn's disease and then ulcerative colitis. So the detailed questioning about, you know, the symptoms should include actually some of those questions that might be left out when we just, you know, look over or usual, you know, routine question checklist with the, you know, textbook questions. This is the same here. And then I think a very, very interesting study from Canada actually that looked at what is the patient treatment preference, what is the main driver for choice of therapies across the board for IBD patients. And in this study, they were identified two very distinct patient profiles. One was driven by efficacy. You see the blue bar is the highest there, efficacy. And the other one was driven by side effects. So basically, this survey has highlighted that, of course, you know, not all patients are the same, but there are probably two main patient characteristic profiles. For one type of patient, the efficacy is really the winner, so you have to focus really all the discussion around efficacy. Of course, you know, you share the data on side effect, but that will be to lesser value to those patients, and they will make their primary decision on the efficacy data, while the other patient group, they are much more interested in the whole picture, or in other words, the totality of the evidence, and to see, you know, whether really the efficacy and side effects are balanced, and they have really a balanced, you know, outcome and win from the given medication. If it comes to the oral medications, then you see that there is some difference across the board among the countries. Some patients in different parts of the globe may have more, you know, problems about, you know, how they swallow the medication, or the low blood burden, while other countries report mainly the symptom control and lower risk of flare on the long run as the main, you know, important driver of their decision. Again, this might be, you know, based on ethnicity or geographic location. Just wanted to highlight that not all the patients around the globe have the same preferences. So whenever you discuss the most appropriate therapy with your patient, you have to be aware of, you know, the geographic location, and if there is some really special, you know, knowledge or difference around, you know, the patient preference in that region or country, that should be taken into account as well. For the biologicals, there was a little difference between Crohn's disease patients and ulcerative colitis patients, at least in some surveys. In Crohn's disease, I would say, you know, because these patients might have really very often, you know, out of the box type of complications, and not only, you know, intestinal complications. I would say it's a little bit more rational that they take into account the full, you know, totality of evidence and the side effect profile of the medication as well. While in ulcerative colitis, when the symptoms are usually much more straightforward with diarrhea, urgency, and bleeding, then the most important determinant of the patient choice was the relief, time to relief. So in other words, the therapeutic efficacy. Again, this is a very practical discussion whenever you try to discuss the next medical therapy for your Crohn's disease patient, that you might really highlight, or might need to highlight, all aspects of the given medication and mechanism of action of the different medications. While in ulcerative colitis, probably the patient who have a lot of urgency and bloody stool and diarrhea, they will be much more interested in the quickness to have, you know, symptomatic relief and getting away from the symptoms. Safety profile, of course, you know, is here, that you see for oral medication, once daily dosing. There are, you know, for oral medications, you know, again, efficacy, side effects, and then the pill burden probably that are important. Again, I think for oral medications, no surprise that the frequency of dosing, and especially if you have to take it the lunchtime as well, as to whether morning or evening only or once daily, then the convenience changes, meaning the highest burden is associated with lunchtime medication. And then if we really want to summarize all the knowledge about, you know, the patient preference around the medical therapies. Then you see efficacy, side effect, and the third pillar that you discuss with the patient is convenience, how much control they need, when do they have to take it, the pill burden, the route of administration if it's not oral, and the frequency of dosing. So these are the things that matter, of course, for the patient and the physician as well. So in conclusion, I hope I could show you that we still have to do a little bit of teaching around how we share the information and how we give or information to our patients at around diagnosis on the disease or on the long-term plans, therapeutic plans, or outcomes. If the patient has an active state, whether it's really the flare or the first clinical activity, then the most important discussion point is the medication, and then the efficacy, side effect profile, and convenience. And if the patient again has a remission and stable disease and the long-standing disease, then of course the focus is more revolving around the future possibilities, new therapies, and the landscape of the IBD research. So this is the things that we have to know about the global priorities. I think that the access, the quality of care, shared decision making, and probably providing much more individual or independent online tools and a little bit of self-management of the patient is what we have to expect in the future. And that is where I would stop. Thank you for your attention. And I hope that we will have just a small discussion. Thank you very much. Please unmute yourself, and then I'm happy to take questions. So Emily should just lead the discussion. I'm just checking, and I will also open up the chat box. So if you don't want to ask questions, but just type questions, that's okay as well.
Someone I think was going to ask a question, so we'll see if they write it. They may write you privately, or actually you can
just to everyone,
or write me, yeah, or whomever.
Wherever. Yeah. It was very clear, and it's late. So what I wanted to tell actually, and why I chose this topic. I don't know how surprising you find that, but actually the research around this is very limited. So I think, despite the fact that this is really a very important, I think, area of the quality of care and interaction with the patient, there was really not much research targeting about patient needs or patient preference and interaction with the IBD center and quality of care. So when I actually wanted to gather the information around this, and that was really my plan when we tried to change the quality of care program at our center, then I had a hard time because it was just really a sparse of data, lack of data. So this is where we started, and now we have a question from Mike. So what is the next biologic after Remicade and Humira? So I guess this is a very good question. The sequeling of the biologicals, this is of course, for the moderate and severe patient, both colitis and Crohn's, a very important question. I start with the good news. We have a lot of new mechanisms of action. So we have really a lot of drugs that we can offer, and there are many drugs in development. There is no good head-to-head trials, especially not necessarily after the biological exposed patient. However, we have clinical trials that looked at the efficacy of the new mechanism of actions. If I highlight them, they are the IL-23 receptor antagonists, so that would be known as Stelara at the moment. And then we have the anti-integrins that would be known as Entyvio, the patients. And all those studies included both biological naive and biological exposed patient, and part of it was exposed to anti-TNFs. And luckily those patients they had still an efficacy signal, after they lose a response to the anti-TNFs. So luckily, all the new medications, they have still something to offer when the patient has already, failed the anti-TNF medication, which is in the question, the Remicade and Humira. Whether it's really the anti-integrins, so the Entyvio or the Stelara, then we have to discuss about the patient profile, the patient preference, I guess, as well. And Crohn's and colitis might be a little bit different as well, since Crohn's might have a little bit more, efficacy signal for the Stelara. However, Entyvio has been showing efficacy as well. But then, of course, it depends on really more the exact patient profile. How would structure that discussion? And for ulcerative colitis, tofacitinib, so Xaliance is an option as well. And to be honest, despite the black box warning, the Xaliance efficacy data after anti-TNF failure was quite strong as well. So for ulcerative colitis, we have 3-4 type of medications. For Crohn's disease, we have at least 2. From Ryan to everyone, are there any new medications in the pipeline for CD and UC that I'm excited about? So actually, at the moment, we have quite a bit to offer. So at the MUHC, at the McGill IBD Center, we are involved in most of these programs. And we have some new IL-23 receptor antagonists. We have some new JAK molecules. So that will be something similar to tofacitinib, like hopefully to leading to lesser, side effect profile or more favorable side effect profile. And we have some new, not all anti-integrins, but I would say that maybe the, let's say the movement of the leukocytes from the lymph nodes would be blocked, and they are called S1P inhibitors. So these are the main 3-4 mechanisms of actions in the area that are having new drugs that could hit actually the market soon. So what I think personally, then if we would have an anti-integrin, and the name is etrolizumab, for which the program is ongoing, that would be a little bit more having an efficacy signal for both colitis and Crohn's. That would be a great add-on. Similarly, for the new JAK molecules, the first one that was approved, that's tofacitinib. The new ones are called upadacitinib and filgotinib. The programs are ongoing, and they show in the clinical trials a strong signal for efficacy for both Crohn's and colitis. And why they are really a different type of medications? Because they are oral, they are easy. So if you have, really the choice of offering the patient efficacious therapies, new therapies, so to say, subcutaneous, IV, and oral, then I think still, quite a bit of the patient would choose the easiest route of administration. So for, once again, for the JAK inhibitors, if they would have the new generation, a more favorable safety profile, that would be really, I guess, a hit. And these are the ones that are really at the end of the development. Any other questions?
I have a question.
Please.
Thank you for that really interesting review of the literature on this.
Mm-hmm.
So I'm wondering, I think about myself and other patients, and it's so heterogeneous, I guess, that it makes us experts on our own disease, but not always on, others' disease. And I'm wondering, like, what are the best tools for a patient to use? Like you mentioned some of the apps, like what are the best tools for us to use in order to communicate or track our symptoms or our quality of life, that kind of thing?
So I think it's really like, what you can offer and what you have as channel and what you agree with your treating specialist or with your group of, IBD specialists that you're having the care with. So myself, I think, that the more you have, more channels, the better. Once again, at the McGill Center, what we have of course, a phone line. We have an email 24/7. We come back with a rapid access, and we see our patients like, in person, even despite COVID, within 2 to 3 days if needed. So we try to be there. We try to be visible. That's one point. Number two, there was a some programs already, developed in Canada as well. I would not like to mention the name now because they are not, fully evaluated and used at the moment. But there are, IBD tool, kits on the net. The most important that you have a structured questionnaire there that are really, trying to assess a little bit more structured how you feel. That's the question, how you feel. And then if they are, going along the clinical scores, it's easy because in ulcerative colitis, it's really the stool frequency, the night urgency, and the bloody stool number. In Crohn's disease, it's much more complex because the symptoms are more heterogeneous, but probably again, the pain and stool frequency and the urgency and fatigue would be the most important. So whenever you have these type of, structured, questionnaires in a tool, and then at the end they will tell you that, oh, look, this is your own, line of stability with the symptoms of IBD, then I'm happy. Whenever I do my, patient note for the given visit, I actually list these symptoms, not just give an overall opinion that the patient is in control or, losing the response or in flare, but I try to be structured and tell really she didn't have or he didn't have any diarrhea now, or the usual 2 to 3 stools that the patient usually reports, but no night urgency, no pain, no fatigue. So really get a more overall picture from the clinical symptomatics, and then we build on that with the biomarkers, and then sometimes endoscopy and imaging. The biomarkers, and again, you could ask me and I would say you're right, it could be more individualized. For some patients, actually the stool marker, what is called calprotectin, the stool marker of inflammation, is the best marker. For some other patients, mainly Crohn's disease patients, they have a good response for CRP. So if you have the combination, this is why I highlight that of, sometimes knowing your own, CRP or calprotectin value and whether this is in line with when you are in control or this is going, really out of the box. And then you have also alongside a change in your usual symptoms. In the usual symptoms, again, I will highlight that whenever you are stable, this is the sign, when you have to really reach out and you say, okay, I need an earlier than scheduled follow-up, or we need to discuss. And it might be IBD related, sometimes not necessarily. In the era of COVID, I guess a lot of things are really based on anxiety and unfortunately, other than IBD stress problems, hopefully we will be more, relaxed soon. 2 questions here. I will get the short one. So that's any thoughts on probiotics. Probiotics can again help with some symptomatic relief, especially if you're having occasional type of, more stenotic or, blockage type of, but not complete blockage type of symptoms. They could help. They have no evidence on any of the probiotics that it really changes the inflammatory process, with the exception of ulcerative colitis patients who are well in control. In those patients, only 1 strain or 2 strains. One is the E. coli Nissel, the other one, which has now more, question marks because there were some publications published last 2 years against as well, the VSL-3, that they could help you to, maintain remission, so have lesser risk for flare, but not to treat active disease. On the other hand, if you have really diarrhea, then the probiotics, they can even add you 1 or 2 more loose stools. So symptomatically, they're not only beneficial. Whenever, once again, you have more blockage and pain, predominant type of disease, then they might be of benefit. The inflammatory control is lesser proven. Okay, my experience as IBD patient, we had a lot of doctors who are not familiar with the latest research. I would like to express the desire for more doctors to be well educated on contemporary research and therapies. That's true. I would say that there are at least 3 different types of gastroenterologists. So you think gastroenterology is a subspecialty, but it's not just a subspecialty, but we are even further divided. And at the IBD Center, we are called IBDologists because we are really interested, in IBD patients and all that burden and all that care. However, there are some who are really working more with liver. There are some who are really working much more with biliary problems, and then therapeutic endoscopy. And they have a lot of very special questions as well. So if you just, let's say, go to any gastroenterologist, then some of us are actually not so much familiar with, the very latest development of the IBD care and IBD research and therapies. But this is life, so you really have to look at, the possibilities and hopefully get, an access to a more specialized IBD specialist or an IBD center. So that's correct. Any other questions? If not, then I thank you very much, and I pass on to Emily to a little bit discuss or share information on our upcoming event. And I very much thank you for being present today, and hopefully talk to you soon at our fundraiser or the next educational event. Thank you.
Emily, let me just thank Peter, Dr. Lakatos, for another great presentation. I'm glad we make these more often than we used to. I think it, definitely is part of our mandate, and part of our mission is to not only raise funds to help patient care and research, but to also educate people suffering with these diseases and their families and their friends and so on. So you are definitely the head of our group, and you carry that mantle very well. So again, thank you so much. And I look forward to seeing you virtually at our fundraiser. And I hope many of you who are watching tonight can join us as well. And Emily will tell you more about it right now.
Sure.
Thanks, Peter.
Dr. Lakatos, if you want to give me hosting duties again, I could just quickly share the screen also and show the poster for the fundraiser. So first of all, I also just want to thank everyone for signing on. I know that 7 o'clock maybe was a little bit too early. We set this a while ago, so it was 7, but maybe we'll try and aim to do them at 7:30. So our next event
you can share, Emily, I guess.
Okay, great. Our next event is our virtual fundraiser taking place Thursday, November 12th. Let's see if we can do this. Can you see that here? It's just a PDF.
Yes, you can.
Yeah. Okay. So it is an evening benefiting the group, all the clinics that you all attend at the MUHC, at the General, the Children's, and the Jewish. We are having Oz, the mentalist, again this year. He has been doing many things on Zoom these last few months, and he's incredible. He's back. He was here for a couple of years ago. And even more importantly, this evening is going to be honoring our very beloved late chair, Dr. Ernie Seidman. And Dr. Seidman, we will be, doing a little video of him at the beginning, and this evening will be in honor of him, of his memory. And then we will be proceeding just to have a really nice night. And I know that Dr. Seidman loved O's at the last fundraiser also. And so this will be a special evening for everyone. And we really hope to see you there. All the information can be found on our website, McGillIBD.ca. You can also follow us on Facebook, and I always just post the events there. This event, this session and video will be put up on our Facebook, on our website, and I will email everyone who got the email from me today with the video as well. So if you want to refer back to anything. So thank you very much. And I really hope to see you November 12th. Any other parting comments, Dr. Lakatos?
No, I thank you very much again. I hope, once again, that these type of events really give us a little time to get together. And as you have heard, next time we celebrate, and we also, try to honor one of our, beloved colleagues. Thank you.
Exactly. Thank you, everyone. Take care. Stay safe. Have a good night. Bye.